Bismillahir Rahmanir Rahim. Rabbi shrah li sadri wa yassir li amri wa hlul 'uqdatan min lisani yafqahu qawli. I am Dr. Mudassir Shabazz, Associate Professor, Sahara Medical College, Narawal, and today we are going to discuss about the clinicals of learning. Before we start learning about the clinicals or applied anatomy of the lower limb, there are certain things that a student should have clear in his mind before starting learning about the clinicals. The very first question that in the mind of the student that should come is that has he really understood the normal anatomy of a structure? If you believe that he have really understood the normal anatomy of any structure, then it is a common sense that many of the abnormalities are automatically understood by applying the common sense. And the example I have given here, that if you know the location, nerve supply action of a muscle, then if the nerve is damaged or a certain muscle is not functioning, then it is possible that we should think that if the muscle is not functioning, taking action, then it is clear that the nerve of supplying that muscle is not working properly. And if we know already that the nerve is damaged, then we know the action of that muscle will be lost, and we can understand that. Similarly, if we know that one structure is passing very near to a bone, and if it is fractured there at that point, it means that that nerve is most probably going to be damaged by fracture of that bone. So, if we understood the anatomy of a normal structure, we can understand the clinical of their structure. So clinical means the abnormality in the normal one. So if we know the normal one very clearly, so we can understand many of the abnormalities. And while studying anything, while thinking or learning about anything in your life even, then think about the common things first, not the uncommon things, most likely things that are going to happen, that going to occur first, then the uncommon things. And the very much important point is that at the level of first year and second year, that the preclinical, so means that how much we are supposed to know about the clinicals of that structure. That is very important. Sometimes we waste much of the time in going into very much detail of about the etiology, about the pathophysiology, about the treatment of that clinical scenario. We are not supposed to be a clinician. If you have to treat the fractures of the femur or tibia, then you have to become an orthopedic surgeon. If preclinically, we should know a little bit about what will be the consequences if the fracture has occurred of any bone. So, but the problem with us, while we are learning about the clinicals, that nowadays the questions in the exam, the professional exam, they come in a way that the clinical scenarios are given, and by that clinical scenario, we have to sort out that what normal anatomical structure may have been damaged, and we should know about the relations of the that structure. Then, if we have to tell the normal anatomy of that structure basis on that clinical scenario. So, to sort out, to understand those clinical scenarios, we have to know a little bit or somewhat detail of that clinical abnormality. So, in my opinion, if we keep these things in our mind beforehand, it will be easy for us to understand the clinicals and clinical scenarios. Now, here is the slide. Other slides are given And here is a slide showing the two angles. So whenever you are dealing with the fracture of the neck of the femur, in which there will be disturbance of the angle of inclination, angle of torsion, so we should know about the angles, angle of inclination and angle of torsion, to understand the fracture of the neck of the femur or fracture of the femur as such. So this normal angles you should know. And again here is shown about the angle of torsion, and here is the femoral neck axis and dicondylar axis have been shown. So normally we should know about this. And then we can understand through this, while knowing these abnormalities, we can now understand the coxa vera and coxa valga. So, coxa vera and coxa valga, when the angle of inclination is decreased, the condition is coxa vera, and when angle is increased, then the coxa valga. Vera and valga, these are the Latin words. While I was thinking about the valga, the thing come into my mind is the vulgar one, means deviating from the normal ones. So vara means the thing coming closer together, and valga means it is going away. So when it is going away, the valga, the angle will be increased. When it is coming closer, then the angle will be decreased. So this is when the joint in limb is deformed, that the distal element, the shaft of the femur relative to the femoral neck in this case, deviate towards midline or away from midline. Valga means away and vara means towards. So when the angle is disturbed, we can say coxa vera or coxa valga. So these terms, why we should know about these two, coxa vera and coxa valga, in which the angle of inclination is decreased or increased. So when we are walking, normally the two knees, they don't strike with each other while we are walking. They are away from each other. But if they are closer together, and while walking the knee will strike with each other, there will be difficulty in walking. And valga means they are away. So when you are walking away with valgus, coxa valgus, you will feel difficulty. If you have a broad-based gait, it means the two foots you have to put, they are very much away from each other. So that's why we should know about the coxa vera and coxa valga. These abnormalities can be due to trauma, or these can be normally present. So here is shown about the example of coxa vera. It means angle is decreased, and the coxa valga, in which the angle of inclination is increased. So these two conditions, coxa vera and coxa valga. Now the next thing given in the book is the bone graft. Here we see in this diagram, this is tibia and here is the fibula. So shaft of fibula between the two ends has been removed with the nutrient artery. So this is a common example taken, that the bone can be taken from this one as a graft, and the major part of bone is not, if it is at other side the bone is destroyed, then the replacement can be done with this bone. The fibula is a common source of bone grafting, and after a segment of shaft has been removed, walking, running and jumping can be normal. So that's why this bone, the shaft of the fibula, can be used. And this is secured at its new sites, the fibular segment, by taking the nutrient artery with it. So bone grafts can be used. that the part of the bone, and this can be used somewhere. Here you can see the neck of the femur is fractured. Here the part of the fibular graft has been passed through the neck of the femur into the head, and in this way the neck is stabilized and the head is closed in the hip joint. So this bone, this graft will maintain the integrity of the neck of the femur. So it is a fibular strut graft here, and here the nutrient artery has been re-established. Blood supply has been re-established with the nutrient artery from the branch of the femoral artery has been taken. So nutrition is re-established. Nowadays, this is not used because the metallic screws and other things are available. So these are not taken nowadays. Os trigonum. In this diagram, here you are seeing this is calcaneum, this is lower end of the tibia, and this is talus. If you see the posterior end of the talus, here is a small bone which is separate from the main bone. So why this is so? This can be normal, this can be abnormal. Why this is occurring? It is said that because of multiple center of ossifications, the secondary center of ossification must be here, and that fail to fuse with the main bone, and that develop into a separate bone. So that becomes a separate bone, and this, in this sense, this separate part of the bone from the main bone is named as os trigonum. Okay, so during the ossification of the talus, the secondary ossification center becomes lateral tubercle of talus occasionally fail to unite with the body of the talus. This failure that can cause applied stress during the early teens, forceful plantar flexion, and then become the fully ossified and remains away from, then it becomes hinders with the accessory bone is formed as an osteogonum, and which more commonly this can be bilateral, and this is more common among the soccer players and ballet dancers, because the bone, then that bone separate from it, and then that can cause some problem in the function. So this is os. Os means bone. Trigonum means separate. Os trigonum. Now, here in this slide have been shown the thigh covered by the fascia, deep fascia, and here is a black line which is separating a cross section. So when we cut at this level, we see this cross section. Why I have shown you this? Because we should understand to learn about the cross sections. And while in this cross section, this is anterior, this is posterior, and so this is the anterior compartment, this is medial compartment, and this is posterior compartment. So here you see, if there is fracture here of the femur, this is most probably it can be damaged. So relations of the anterior, posterior, lateral, medial can be understood very importantly by this cross section. And here we see that from this deep fascia, septas are passing inward, and they are separating, forming the different compartments. Here the septa is coming down. This divides this anterior compartment, separates from the medial compartment, and the muscles, they are also enclosed by the facial thickenings, facial septas. So, and the relations of placement of the nerves and vessels in that compartment, they can be well understood by this cross section. Here we see that if this is deep fascia, the great saphenous vein is outside the deep fascia. So it is the superficial fascia. So if we see here is a thickening of the deep fascia that form the iliotibial tract. So we can understand the position of the muscles and the compartments through this, and the cross sections are very important to understand. Similarly, here is the another view of the cross section of the leg, which is shown here, and this is by the compartments have been shown by, this is tibia, this is fibula, and in between the tibia and fibula here, the anteriorly is the anterior compartment, this is the lateral compartment, and this is posterior compartment. And you can see the muscles of the anterior compartment and neurovascular of the anterior compartment. And then you can see the posterior compartment, superficial muscles, deep muscles, and this can be understood through this cross section and placement of the superficial veins. A small saphenous vein is on the posterior side, while the great saphenous vein on the medial side. So what I want to show by these slides is that the cross-sectional study is very much important for understanding of the normal as well as the abnormality that can most probably occur when the damage is to that structure. So for us to study the cross sections is very important, and the student should try it again and again to describe a cross section, to understand a cross sections, how to read a cross section, how to understand a cross section, how to understand the placement of the neurovascular structures, how to differentiate between different compartments, right? And now here is the what in this slide we are seeing the great saphenous vein. If we know the normal structure of the great saphenous vein, means it is starting from the medial malleolus, running upward on the medial side and ending up at the saphenobarics, where it is crossing the cribriform fascia and entering into the femoral vein. So here in between, here is the saphenous nerve coming out and running along the saphenous nerve, and it is connected to the deep veins through the perforators. And here in these slides, the enlarged view of the saphenous opening is shown. And the important thing here to see is that when this great saphenous vein is joining here, great saphenous is joining, there are valves which prevent backward flow of the blood from that vein, the valvular mechanism. And here in this view, we are seeing that from the lateral side, it's a posterior view. This is an intermediate view. In the posterior view, we see that here the small saphenous vein from the lateral side running upward on the posterior side and ending up into the popliteal vein, the small saphenous vein. Inside are the deep veins, and through these deep veins are connected to the great saphenous vein through the perforating veins. These perforating veins, they are also guided by the valves, and the deep veins, they sucks the blood from the superficial vein, and then it is transmitted upward by the muscles pressure generated by compressing the deep veins upward. So here we see the perforating veins, perforators. Through these perforators, the great as well as the small saphenous vein, they are joined with the deep veins. And what another thing we are seeing here, that the saphenous nerve is running down with the great saphenous vein, while this sural nerve is running along the small saphenous vein. So if this vein is removed or cut down, the saphenous nerve can be damaged. And so because this is a cutaneous nerve, so the cutaneous nerve supply of that area will be lost. Here again, if the small saphenous vein is damaged or is taken out for some other usage, and then the sural nerve is most probably can be damaged while removing the small saphenous vein. The other thing we see that if the valves they are damaged, so the valvular mechanism not allowing the blood to flow back into the veins is lost. If the valvular mechanism or the between the perforating veins and in the deep veins and the superficial veins, valvular mechanism is lost, so the pressure will be transmitted outside to the superficial veins, so that can be damaged. So having this knowledge in our mind, then we can understand. First of all, deep vein thrombosis. Because the blood flows between the muscles by a peripheral muscular pump pushed upward through the veins, and there are valves here that prevent the backward flow. If these valves are damaged, the blood is pulled down into the legs. Or if you don't move the muscles in your legs, don't do the exercises, then what can happen? That the blood will stay in the deep veins, and what is happening here, the blood tends to clot down, tend to thrombose in this deep veins of the leg. Then what is the danger? So because that the deep veins, this is process is occurring in the deep veins, so this is named as deep vein thrombosis. What is happening here? This small clot from the thrombosed blood is detaching and moving upward, so becoming an embolus. First there is thrombosis, and then it is becoming as thrombolus. So the whole process is called as thromboembolism. That from a thrombus, a part is detaching, becoming an embolus, and this is common sense that this embolus will move to the right side of the heart, right atrium, right ventricle, and from the right ventricle right into the pulmonary circulation through the pulmonary artery trunk and any side of the lung. So this venous stasis, which is cause of this thrombosis, this can occur. Incompetence and loose fascia that fail to resist muscle expansion, then there is ineffective musculovenous pump. The other thing, that the external pressure on the veins from the bedding during prolonged hospital stay as a ties cause bandage. The third thing is the muscular inactivity. In traveling long in the aircrafts and standing for a long time, such as in bus drivers. Similarly, when you are going to have cardiac surgery, which lasts for 3 to 6 hours, during that, if there is no anti-clotting mechanism, the blood in the deep veins, which are now the muscles are inactive, the blood can clot and form the thrombus in the deep veins of the leg. So when these valvular mechanism has been damaged, what results is in this condition: dilatation of the superficial vein, which is called as varicose veins. Varicose veins. This is a very common problem in the society, especially in the ladies and bus drivers, in the hairdressers, who has to stand for a long time, and the blood is pulled down. So this disease can result in them the varicose veins. What is varicose veins? Is dilated, elongated, tortuous, palpable, superficial veins. These are the superficial veins. A result of venous hypertension means the pressure in the venous system is increased. Why it is increased? This pressure, from where the pressure is coming into the superficial veins, this pressure is coming from the deep veins. When the valvular mechanism in the perforators, which are attaching superficial veins to the deep veins, that is damaged, so the pressure in the deep veins, when the muscles will contract, that will be transmitted to the superficial vein, and which will result in the venous hypertension. And what it will cause? The increased pressure, that will cause the dilatation of the vein. And that because they are the thinner part, so they are not muscular, so that will be tortuous, dilated, elongated, and tortuous. So there are stages of these varicose veins. Normal one, here is the stage 1, where the small reticular or spider veins, they are visible. Stage 2, small nodes, they appear in the leg. And stage 3, there is swelling of the leg. Stage 4, there is venous ulcer formation. So these are the 4 stages of the varicose veins. This is for the purpose of understanding or having a curiosity, to fulfill the curiosity. Great saphenous vein can also be taken out as a vein graft. And here is shown the great saphenous vein. It can be taken out right from the ankle up to the where it is joining the femoral vein. So this whole great saphenous vein can be removed. And here we see in this way it can be placed as a graft. One end is attaching at the aorta and other on the right coronary artery. So it's a saphenous vein graft to the RCA, from aorta to the right coronary artery. And obviously this is common sense that this has to be reverse graft, because here are the valves present in this vein. So because valve present, the distal end will be placed on the aorta and the proximal end will be placed on the RCA. So reverse saphenous vein graft. Here is example is shown. Here is the here is another, that the Lima to LAD has been shown. Lima means left internal mammary artery, which is supplying the thorax. The artery has been removed from the inside, has been detached from the thorax from inside, and then its proximal end is originating from the subclavian vein that remains here, and this artery is placed as a graft, the distal end, on the left anterior descending artery of the heart. So it's a Lima to LAD graft. This is an arterial graft, but this is a venous graft, for which the most commonly great saphenous vein is taken. Now, sometimes when a patient comes to the emergency, collapsed, and there is no the venous line, the veins are so very much small and collapsed that the venous line cannot be taken. And in that way, in that time, when there is emergency and you need a vein to give the fluid in the shock, to give plenty of fluid, so in that case, the very readily exposed part is the great saphenous vein, which can be exposed at the ankle. So here the procedure we are seeing here, the cut is made on the anterior to the medial malleolus, on the medial side of the anteromedial side of the leg, and then the great saphenous vein is exposed, that is cannulated here with the venous cannula, with the cannula, and then through this the rapid fluid, blood or other thing can be given. Here, both the transverse or the longitudinal seam there can be used. Although it may not be visible, but it is constant at this place, so this can be readily exposed. This is called as great saphenous vein cut down. So if you go to the hospital and see a patient with a cut down on the great saphenous vein, so you can very well understand how this can happen. So if you are taking the great saphenous vein, so what nerve is running along with it is the saphenous nerve, and this can be damaged, and there will be sensory loss on the medial side of the foot down to the biunion area. So here will be the loss of the sensation when you are taking the great saphenous vein. Compartment syndrome. Compartment syndrome means there are certain things, certain symptoms that are going to appear, not single one, certain the multiple one, which are occurring in a certain compartment. So that will be called as a compartment syndrome. So it's a condition that occurs when injury causes generalized painful swelling or increased pressure within a compartment to the point that blood cannot supply the muscles and nerve with oxygen and nutrient, leading to muscle and nerve death due to ischemia. So that's why I have shown you why you should know about the different compartments we have already seen. Normal pressure in a compartment is a 5 to 50 millimeter of mercury, but if this pressure is increased from 35 to 40, then this compartment syndrome will develop. So here uh, is a Madsen definition in 1980s that the compartment syndrome is a condition in which increased pressure within a limited space compromises the circulation and function of that tissue. So that is definition by the Madsen's definition in 1980s. And if I go back here in this, I have shown you the cross section of the leg, and here if there are different compartments. This is posterior compartment, lateral, anterior compartment. So if there is the increased pressure in the posterior compartment, and this will compress the nerves and the vessels, and these muscles will be affected. So this is a compartment. This can occur anywhere in the upper limb, the lower limb, anywhere in the body where there is a compartment is limited by the fascia. So the pressure in that compartment will increase. So I have chosen these two diagrams to show the cutaneous nerve supply of the lower limb. These should be very well understood and by the students, because when you are examining a patient, the nerve supply, then if there is a loss of nerve supply at a certain area, then you can understand the which area can be affected. Here is the dermatomes shown here, that the which dermatome is supplying which one. So if the sensation is lost here, S1, it means that either the nerves carrying the fibers from the S1 they are damaged, or the spinal cord level S1 is damaged, is damaging the nerve to S1 in the lumbosacral plexus. So if you have loss of sensation at this level, L3, or this L4, L5 level, it means either the nerve supplying this area is damaged away, or in the spinal cord level, the disc between the L4, 5 is compressed, and nerve coming out supplying this area is damaged. So these two diagrams are very important for the student to learn, to understand the clinical problems by the damage of the nerves can be understood. So next is the psoas abscess. We will see how psoas abscess is formed. So and then the different muscle paralysis, what will happen by paralysis, and then the damage or fracture of the patella. So we will see it later on. I think so. This is enough for here, and inshallah we will discuss these things in the next lecture.